Hello, this is Dr. Robert Fisher giving an educational talk, I hope, on polytherapy versus monotherapy with anti-epileptic drugs. Polytherapy is sometimes called polypharmacy, and anti-epileptic drugs are really a bit of a misnomer since they do not prevent or cure epilepsy, but just suppress seizures. Nevertheless, the term is entrenched, so I will use it. This educational video is intended mostly for physicians and medical personnel. However, it's fine for anybody to watch it. I received no compensation for preparing or presenting the material, and permission is granted for public educational use. Imagine that a healthy adult is just diagnosed with idiopathic generalized epilepsy, or for that matter, focal epilepsy. Would you start them on one or two drugs? If you start them on one drug and that drug did not work, how many times would you change to another single drug before you would consider combination therapy? Well, a survey of 42 experts voted for 3 monotherapy cycles before trying polytherapy, before trying 2 drugs together. What is the logic or rationale or evidence for that? Is monotherapy better than polytherapy, or vice versa, or does it depend? Well, in the 1950s, polytherapy was the rule. I'm showing a box of phenytoin and phenobarbital in combination therapy. It'd be started off on one pill that contained both. That was the case for quite a while, but then it started coming under question because of some of the intrinsic advantages of monotherapy. Namely, monotherapy has fewer drug interactions because there are fewer drugs. It's easier to attribute side effects to a particular drug when the side effects occur. Adherence, which used to be called compliance, is simplified. It's more convenient to take one than multiple medications. Patients psychologically feel healthier when they're on fewer numbers of medications, and it is typically less costly drug for drug. So on the basis of those advantages, thinking and sentiment began to swing in the 1960s and 70s towards monotherapy rather than unnecessary polypharmacy for epilepsy, often championed by the epileptologists from London, Dr. Shorvan and Reynolds. They said, although anticonvulsant polytherapy has been widely and traditionally used in the treatment of epilepsy, there is little evidence of its advantages over monotherapy. It does, however, lead to problems of chronic toxicity, drug interactions, failure to evaluate individual drugs, and sometimes exacerbations of seizures. So numerous studies were done, typically with small patient series and often uncontrolled, showing decreased side effects or increased efficacy from reducing polypharmacy. Now, side effects are a really key issue in deciding how to handle seizure medicines, because no study has really shown that one single anti-epileptic drug is significantly more efficacious than another in a head-on-head comparison. But in an individual patient, they may be, or they may have more side effects. A few years ago, Joyce Kramer and I and our colleagues developed the Personal Impact of Epilepsy Scale, PIES, that measures the impact that epilepsy has on a person's life, and divides this into 3 subscales: 8 questions on the impact of seizures, 8 questions on the impact of medication side effects, and 8 questions on the impact of comorbidities such as depression, anxiety, not being able to drive, not having enough money, worrying about when the next seizure is going to occur. And then there was a 25th question on what is your overall quality of life. So what do you think had the greatest impact? Was it the seizures? Was it the side effects? Or was it the comorbidities? Well, it was the comorbidities. But the side effects had more impact than seizures, including in some people who would break things with seizures. So therefore, we need to be very cautious when we're making combinations of drugs or even using a single drug in very high dosages when we're producing side effects every day, because the patients are going to like that even less than having seizures. If you choose to do sequential monotherapy, you're going to run into some pragmatic issues. Usually you will overlap drug A with the second drug, drug B, so that you maintain protection as you're switching from one drug to another. You don't want the patient to have a bunch of seizures during the switch. However, the overlap is going to produce additional side effects and complexity such that the regimen and titration might very well get screwed up. It often does. There are a few drugs, which I may mention, although it is off-label, that can be switched, I believe, immediately from one to another because they are so similar and their actions are on the same receptor or the same channels. And this includes gabapentin to pregabalin, or the reverse, carbamazepine to oxcarbazepine or eslicarbazepine, or the reverse, one benzodiazepine to another, with a possible exception of clobazam, which is a 1,5 substituted benzo instead of 1,4 like all the others, and levetiracetam to brivaracetam. Now, once you have accomplished a switch from a single drug to two drugs, you will be considering, can the first drug be then taken away so that you have accomplished sequential monotherapy? Unfortunately, that can be hard. In the first case, the second drug may not have helped, so you don't want to rely on it as a continuing therapy. In the other alternative, the second drug has helped, and the patient is seizure-free, side effect-free, and happy now, and really doesn't want you to change anything. So for some patients, adding a drug is a one-way valve. Switching AEDs does not necessarily lead to seizure freedom, even though experts said they would try it 3 times. Of those seizure-free on a first drug, a classic study of Kwan and Brody in 2000, published in the New England Journal of Medicine, showed that patients were only seizure-free 9% when switched to monotherapy onto second drug, and it was about 5% if you went with a third drug. These results are similar to the results seen in the VA cooperative anti-epileptic drug trial. Another way of saying this is that refractory or drug-resistant epilepsy makes itself evident early. You don't have to search for 20 or 30 different combinations trying to find the magic right one for the patient. Of course, even though a person might not become seizure-free, they might become better or they might have fewer side effects, and those can be goals of making changes. In the 1990s to the 2000s, the pendulum began to swing back again towards polytherapy, perhaps not saying that's what should be done, but at least being more tolerant of it as something that you might want to try when monotherapy is not working. A survey found that outpatient polytherapy for epilepsy was 20 to 51%, and inpatient polytherapy for epilepsy up to 65%. All of our modern anti-epileptic medications have been proven in clinical trials using polytherapy. We haven't until recently had monotherapy trials because we don't want to put seizing patients on placebos. The recent trials are for historical validation of monotherapy. And this is a bit of a shot in the arm for polytherapy if you consider that all of our new drugs have been approved via polytherapy trials. The ideal effect of a combination would be super-additive efficacy, more than twice as effective than each alone, and infra-additive side effects. I'm not sure that I can give you any 2-drug epilepsy combination, however, that meets this ideal goal. There have been several studies comparing monotherapy to polytherapy, but 3 of them are particularly notable for relatively large numbers and controlled methods. Of these three studies, two of them showed no difference, and one of them did show a synergistic effect of a particular polytherapy. That synergistic effect in a Brody and Ewan study was lamotrigine plus valproic acid, as opposed to phenytoin or carbamazepine plus valproic acid. And this effect was beneficial, producing fewer seizures, meaning lower down on that curve that you're seeing, than the other two combinations, even independent of the well-known pharmacokinetic interaction between lamotrigine and valproic acid, such that valproic acid raises the lamotrigine levels. In the Deckers and Hexter study of 2001, monotherapy was about as effective as polytherapy. I've circled the 86% seizure-free at 12 months versus 74% seizure-free at 12 months, showing no difference. In this study by Beggy et al., adjunctive therapy versus alternative monotherapy in patients with focal epilepsies who had not benefited from a single drug had a cumulative probability of remaining on treatment the same, whether you gave add-on therapy or alternative monotherapy. The concept of drug load is interesting. This normalizes the dosage of your drug against what is a typical therapeutic dose, usually somewhat low end, but still therapeutic dose of a medication. In other words, is it better to give twice the therapeutic dose of one drug or to give the therapeutic dose of two drugs added together? Well, this graph that shows the adverse event profile as a function of the anti-epileptic drug load on the left for monotherapy and on the right for polytherapy has two flat regression curves. So it doesn't really appear to much matter in this case, even controlling for drug load, whether you use monotherapy or polytherapy. Emilio Peruca, the former president of the International League Against Epilepsy, said, although the suggestion has been made that adverse events are more likely to result from combining anticonvulsants having a similar mode of action, our knowledge of the pharmacology of individual agents is insufficient to allow a reliable prediction of the clinical effects of specific drug combinations. If any of you in the audience are young clinical epilepsy researchers, this would be a nice problem to tackle. What might explain success of combination therapy for epilepsy? Well, here are several theoretical possibilities. One is there may be superadditive efficacy, as there was in the case of valproic acid and lamotrigine, but I think this is quite rare. It might be possible to avoid superadditive side effects. If a person has ataxia on high doses of phenytoin, but the phenytoin is active against the seizures, it might be worthwhile to lower the dose of phenytoin and add another medication that does not cause ataxia. It's been suggested to use drugs with different mechanisms of action, and I will come back to that in a moment. Certainly important are individual patient susceptibilities and preferences. Physician experience with usage is key because there are so many possible combinations, and there are undoubtedly unknown factors affecting the success of combination therapy. Opinions have favored choosing drugs with different mechanisms of action. James Farandelli, a noted epilepsy pharmacologist, commented, "It is better to combine AEDs with different mechanisms of action than to prescribe combinations of AEDs with similar mechanisms of action." Quan and Brody said, on the basis of current, albeit limited data, it is reasonable to establish combinations with potential complementary modes of action. I would suggest to you that not only complementary modes of action, but avoiding additive side effects would be a logical way to choose a combination of drugs. You don't want to choose drugs that make you ataxic, phenytoin, carbamazepine, gabapentin in combination. You don't want to choose drugs that cause metabolic syndrome, weight gain, high cholesterol, such as valproic acid, carbamazepine, and gabapentin. Weight loss is caused by topiramate, zonisamide, and felbamate. And topiramate and zonisamide and acetazolamide also can cause kidney stones. Mood changes with levetiracetam, phenobarbital, perampanel, and sedation with phenobarbital and the benzodiazepines. I suppose if you're going to combine drugs, it might be possible in some cases to counteract side effects. For example, weight gain of valproic acid with weight loss of topiramate or zonisamide. This rather busy slide groups drugs in a simple way according to mechanisms of action. However, I say it's an oversimplification because every epilepsy drug that I know, with the possible exceptions of Gabatril, which is a GABA uptake blocker, and vigabatrin, which is a GABA transaminase metabolism inhibitor, are in themselves really polytherapy because they have multiple mechanisms of action. But in a simple sense, these are some of the predominant mechanisms for these drugs: increasing GABAergic function, blocking sodium channels at different places, blocking calcium channels, blocking glutamate, interfering with carbonic anhydrase, and miscellaneous other novel mechanisms. So if you're going to make a pair, you might take the Chinese menu approach by choosing one from column A and one from column B. For example, clobazam, which increases GABAergic function at the GABA receptor and therefore increases inhibition in the brain, might very logically be paired with perampanel, which is a drug with a novel mechanism of action to block the AMPA receptor of the glutamate channel. And there you get a push-pull effect of increased inhibition and decreased excitation. Similarly, you could choose to pair oxcarbazepine with levetiracetam, topiramate with rufinamide, lamotrigine with valproic acid, which we mentioned above, or lacosamide with pregabalin. And like a Sudoku puzzle, you can sit down and play games drawing many arrows between different boxes and then going back to the previous slide and verify from it and from your own experience that the mechanisms of action are different and the common side effects are different. Conclusions are these. Monotherapy for epilepsy is desirable when it works, and it ought to be the first approach for new onset epilepsy. However, polytherapy may benefit some who are not tolerating or benefiting very much from monotherapy, and I think we're past the time where you have to feel ashamed to use polytherapy. The evidence does not yet mandate the choice of combinations, but one rational method would be the one that I mentioned to you, which is to choose combinations that avoid additive side effects and employ different mechanisms of action. You should consider individual patient susceptibility factors and desires, because you can tailor your drug regimen to the side effects that they want to most avoid. And it's very important that you consider your own familiarity with combinations. So how do we choose our drugs? This is one method, which I call the unblinded, single-tailed test. This is a picture that I took from an old edition of the Stanford magazine, and as you see, it is pointing to the end. So thank you for your attention on polytherapy versus monotherapy in treatment of epilepsy. Glad you could come.